Dear colleagues and students, today this is the fifth wave of the Neuro Expert Academy. After finishing the 3 waves of stroke, and then we started one wave for multiple sclerosis. And this time we are honored to have with us in this 5th wave our dear guest, Professor Alex Rovira, Professor of Radiology from KIMCAT, Barcelona, one of the most important and prestigious MS centers across the world. Well-known figure. He visited us many times in Egypt, especially during the Magnums and Summit meetings, especially in November. Actually, we were planning to have him with us next November, but unfortunately, because of the COVID era, so we decided that he can share with us today his presentation virtually. Also, it's a great pleasure and honor to have with us my dear friend and colleague, Professor Dr. Magd Zakaria, the president of the Multiple Sclerosis Society. And I will let Dr. Magd to introduce Professor Alex. And after finishing the presentation with Dr. Alex, you are free to ask a question. You put your question in the Q&A and we'll take them. The mic is yours, Dr. Magd.
Thank you very much, Dr. Hani. And of course, it is our pleasure and honor to have with us Professor Alex Rovira, Professor of Neuroradiology in one of the most important centers of multiple sclerosis in the world, KIMCAT in Barcelona. And Professor Alex Rovira is part of the Magnums group and is part of all the criteria for MS diagnosis, the McDonald's criteria. Actually, all of us, we all the time see the name of Professor Rovira on all of the publications, the important publications concerning MRI and MS and even clinical trials. So the list of achievements is so large and so big. But because Professor Alex knows that he's a dear friend of us, I will just say that we are honored to have you with us, and we will listen to your presentation, and I'm sure that we will have many questions, because these questions are not addressed only to the topic of MRI and the emerging MRI features, but they are addressed to the king of MRI, Professor Alex Rovira. So please, Professor Alex.
Well, thank you very much for this kind introduction. It's for me a great pleasure and a great honor to participate in this meeting. Unfortunately, it's not a live meeting. I love to stay back in Cairo, in Egypt. I spent very good times in the past visiting your country. But let's talk about the MRI in MS. And when they invited me to participate in this meeting, I decided to talk about new things. I'm not going to review what almost everyone knows, but I would like to focus on new MRI features that can help us in establishing the prognosis of the disease and also to improve the diagnosis of the disease, because there is an issue not only in Europe but also in other places in the world in which that reflects an overdiagnosis of the disease, a misdiagnosis of the disease, and I think that is very important that we make an accurate diagnosis. Okay, these are my disclosures that I don't think that will have any impact on the content of this presentation. So let's start with this slide in which I summarize the value of MRI in MS. And we know that this is the most important paraclinical tool that we have nowadays, not only to provide an accurate and early diagnosis of this disease, but also to characterize the disease over time, to predict disability worsening, to monitor and to predict treatment response, and also for detection of some relevant treatment-related adverse events. But we will focus on the first part of this presentation on the role of MRI in predicting disability worsening as a prognostic marker. And there are several papers that have been recently published that try to summarize all the evidence that we have on how we can make the prognosis of the disease. And obviously, there are some demographic and environmental factors. The clinical factors are extremely important. There are some biomarkers such as oligoclonal bands, neurofilaments that now also seems to help in establishing the prognosis of the disease. But obviously I will focus on MRI, and there are several observations that provides evidence indicating that MRI contributes to the prognosis and therefore for the treatment management of these patients. So let's start by assessing which are the measures that we can identify with MRI that are useful for that purpose. And a very simple one is to just count the number of lesions that we identify on the brain MRI that we perform on the initial diagnosis. This is a study conducted in our center with more than 1,000 CIS patients that were followed up for around 7 years. And then in this analysis, we assess the sex of the patients, the clinical symptoms, the presence of oligoclonal bands in CSF. And we found that the number of lesions, the number of T2 lesions on this brain MRI has a high impact prognostic factor and higher than the rest of the measures that I mentioned. So just simply counting the lesions, and we found that the threshold that better identify the patients with a risk of reaching a significant degree of disability after this period of time of 7 years is 10. So 10 lesions seems to be a low number of lesions in patients with an established MS, but in patients with CIS is already a high lesion load and indicates a poor prognosis. But not only the number, but also the topography of the lesions seems to be important. And at least there are 2 or 3 papers that analyze this fact. And in this particular paper, we found that the presence of at least one infratentorial lesion at the time of initial diagnosis, particularly if the lesion is located in the brainstem, also identifies those patients with a higher risk of developing a disability, a significant disability in the next years. Also, the spinal cord is extremely important, and both in the group of London and our group demonstrated that the presence of at least one spinal cord lesions also identifies patients with a higher risk of disability worsening. And this is particularly true with asymptomatic spinal cord lesions. So this has an important fact in clinical practice, in the sense that even in patients without the spinal cord symptoms, patients with CIS, a non-spinal cord CIS, is important to obtain a spinal cord MRI, because the detection of these asymptomatic lesions that happens in around 30% of all these CIS patients also helps in predicting the prognosis of the disease. Another topography, which is really important, although it's a little bit more difficult to analyze in clinical practice, is the cortical gray matter. We know, according to different pathological studies, that the gray matter is commonly involved in MS. Demyelinating gray matter lesions are frequent, even in the early phases of the disease. However, The detection of these cortical demyelinating lesions is difficult with conventional MR techniques. Even if you use a free Tesla magnet, you are going to identify just a small proportion of these lesions. However, we know that there are some sequences that improve the sensitivity of MRI. And these sequences are this heavily T1 weighted sequence called phase sensitive inversion recovery, which I found it is the best sequence you can use for detecting these type of lesions, and also the so-called double inversion recovery sequences, which is similar to the T2 FLAIR sequence that we usually use in clinical practice. So the combination of these two sequences clearly improves the sensitivity and specificity in detecting these purely intracortical lesions. And this is a nice example of a cortical demyelinating lesion identified with these two sequences. So according to this paper by Scalfari, in which they analyzed using these sequences the presence and number of these cortical lesions, they found also that this has the presence, for example, of more than 7 lesions. You can see in this survival curve, identifies those patients with a high risk of converting into a secondary progressive MS phenotype. So assessing cortical lesions also has an important prognostic factor. Another way, this is, I think, a very interesting paper coming from the Queen Square in London, in which they combine in this model the findings on brain, but also on a spinal cord MRI in the same model. And they could demonstrate that the presence of at least 2 enhancing lesions in the brain, plus at least 1 spinal cord lesion, also identifies those patients with a higher risk of converting into a secondary progressive phase. And again, in the same model, they assess the presence of new lesions in the first years after the onset of the disease. And they could demonstrate that new lesions located in the infratentorial compartment or new lesions in the spinal cord also helps in predicting conversion to secondary progressive MS phenotype. This obviously has some implications in clinical practice again, because particularly in the first years, it could be interesting in some patients to scan not only the brain but also the spinal cord in order to identify the presence of new lesions in these areas in order to predict the outcome. Another more classical model is, again, coming from the Queen Square group, in which they have a group of CIS patients that they had the opportunity to follow for more than 20 years. And they assess in this group of patients the volume of the T2 lesions. And they could show in this paper by Fisniku that the increase in the T2 lesion volume, particularly in the first years after the onset of the clinical symptoms, also identifies those patients who will convert into a secondary progressive phase. However, in clinical practice, assessment of the T2 lesion volume is not so easy. We need automated tools that are, some of them are not very robust. So I don't think that we need to do that in clinical practice. I think that we can rely on the presence of new T2 lesions that can be visually assessed quite easily. However, talking about the T2 lesion load, I think it's important also to mention that this measure, which can be useful in the early phases of the disease, is not a good measure in the progressive phases of the disease. Particularly, according to the paper of Lee, when patients reach an EDSS scale of 4.5 points, the T2 lesion load reaches a kind of a plateau. So the patients increase the disability, but the T2 lesion load remains quite stable. And this has been demonstrated, for example, in this particular patient that we have we followed him for several years, and you see that the T2 lesion load remains quite stable. There are no new lesions. There is not a clear increase in the T2 lesion volume, but at the same time, you can clearly see that there is an increase in the degree of brain atrophy. So this reflects that in these late phases of the disease, the inflammatory component, the new T2 lesions decreases, but at the same time, the neurodegenerative component of the disease predominates. And then in these phases, we need to assess the disease by using measures that clearly reflects this neurodegenerative component. This is the clinical profile of this particular patient. You see that entered the secondary progressive phase with disability progression, but only increase in the degree of brain atrophy, but not on the T2 lesion load. And this also leads me to another emerging concept that in fact is not completely new, because we knew this concept of T2 lesion volume atrophy, but was the group of from Buffalo, from Professor Zivadinov, that write a couple of papers regarding this concept. The atrophied lesion volume reflects this apparent decrease in the extension of the T2 lesions, particularly in the periventricular area. And this is a nice example. You see, this is a baseline examination in a patient with a progressive phase of MS. And this is a follow-up performed a few years later. And you see that there is an apparent improvement in the extension of the lesions. But this is not exactly the truth. What is happening is that there is an ongoing tissue destruction. The lesion can shrink or incorporate into the ventricular system in some way. And then always this shrinking of the T2 lesion load is associated with an increase in the degree of brain atrophy. This T2 lesion atrophy exists in the relapsing remitting phases of the disease, but is more prominent, as could be expected, in the secondary progressive phases. And also what is really interesting, according to another paper from the same group, is that this atrophied T2 lesion volume was associated with disability worsening and conversion to secondary progressive MS. So this is another marker of progression, and is something that we have to keep in mind in clinical trials or on different clinical studies. Again, now this introduced me to another, is not a new concept, but an old concept, in fact, is the value of brain atrophy in predicting the prognosis and treatment response. And in fact, I think that we cannot just rely on new T2 lesions or brain atrophy. We have to combine these two measures, and this is exactly what Popescu did in this paper, that for the first time, or one of the first times, she created a model combining these two measures to predict disability worsening, meaning new T2 lesions and changes in the brain volume. And this is particularly relevant in the first years of the disease, first 1, 2, 3 years, to predict disability worsening in the next 10 years. So it's in this early phase where it's really important to assess these metrics. But again, if we talk about brain atrophy, I think that in general, we talk about global brain atrophy. But we know that from a clinical point of view, the gray matter is more relevant. And that's why there's a lot of interest in assessing not just the global brain, but the cortical and deep gray matter. And also, it has been shown that the changes over time of the degree of gray matter atrophy is faster compared to the white matter, which is quite stable over the course of the disease. And in fact, when you assess the gray matter fraction of the brain, you better discriminate between the different phenotypes of the disease, while you cannot do that when you assess the white matter. So again, if you are interested in using the brain volume for predicting treatment response, prognosis, etc., then you have to focus more on the gray matter. But also, what kind of gray matter? We have to focus on the cortical gray matter or on the deep gray matter. And cortical gray matter is affected extensively in the progressive phases of the disease, but in the early phases is more relevant the deep gray matter, in particularly the thalami. So again, this is a nice paper performed by the Magnins group in Europe, and we could demonstrate using a large number of patients with different clinical phenotypes that the deep gray matter volumes is the main driver of disability worsening in MS, and from the different structures of the deep gray matter is the thalami the most relevant one. Unfortunately, we have some tools, FreeSurfer first, that can assess the volume of this structure in a relatively robust way. So it's very easy to obtain, and you can calculate these volumes if you perform a good quality T1 weighted sequence. But not only the brain, the spinal cord also is relevant from a clinical point of view. And in the last few years, there's a lot of interest in using the atrophy of the spinal cord to predict disability worsening. And we know, according to many, many studies, that particularly in the progressive phase, there is acceleration of the spinal cord atrophy. And as I indicated, it predicts disability progression better than other measures, particularly in the primary progressive MS phase. The question is, how can we measure the spinal cord atrophy? One very direct and simple way is to scan the spinal cord. And then we need a heavily T1 weighted sequence, high resolution 3D, such as the images that I show here. And with different tools, you can delineate the whole area, the whole cervical segment of the spinal cord. And from this, you can calculate the cord transverse area, the volume, the length, etc. So you can obtain very easily different measures. But the drawback of this approach is that you have to obtain a 3D acquisition of the spinal cord, something that we don't do in our clinical practice. But we have a solution for that. And the solution is, okay, it's quite common that we use a 3D T1 to assess the brain, because we are interested in assessing the brain volume, for example. It's a sequence that is commonly obtained for the brain. The advantage of that is, with this approach, we also include the proximal segment of the spinal cord. And we can just assess the degree of spinal cord atrophy in this proximal segment of the spinal cord. And this has been done by several groups. This is one of the first papers by a group in Germany, in which they analyze the degree of spinal cord atrophy using brain T1 weighted sequences. And they could find that this cord area is the most significant spinal cord parameter for explaining the degree of disability in patients with MS. Another advantage of spinal cord atrophy compared to brain atrophy, for example, is that the spinal cord atrophy accelerates much more than the brain atrophy in patients with MS. So in this meta-analysis, they show that the spinal cord atrophy is around 1.8% per year, which is faster compared to the degree of brain volume loss, which is around, in patients with MS, of 0.5, 0.6. And for that reason, nowadays, many clinical trials, phase 3 clinical trials, they are using spinal cord atrophy as one of the secondary outcome measures to assess treatment efficacy. So let me show you an example. These are scans, brain T1 weighted scans, in which, as I indicated, we cover usually the upper segment of the spinal cord, and then using different tools, in this case with a spinal cord toolbox, we can really measure the degree of a spinal cord atrophy. Obviously, we cannot do it visually. We need automated tools to do that. The bad thing is that if we analyze, this is a review paper by Tour, and she analyzed the results of different clinical trials in which they use spinal cord atrophy as one of the outcome measures. And none of these studies could demonstrate that the spinal cord atrophy is decreased by the effects of these treatments. They tested in particular in progressive MS patients. The question is maybe still this measure is not enough sensitive to detect very small changes, or what is probably the most likely explanation is that none of these drugs tested in these trials have a real protective effect in preventing the development of spinal cord atrophy. Another issue that I think that we need to discuss is, okay, we talk about brain volume, T2 lesion volume, but do we use these metrics in clinical practice? And the answer is no, we don't use it that. In research, we are using, but not in clinical practice. So why not? And there are several reasons for that. There are technical reasons. The tools are not always available. Some of the tools that are available are not robust. You have to pay. Who is going to pay for that? There are some practical reasons. Already I mentioned the cost and the time. Who is going to perform this? We need some extra time to perform all these measures. And we don't have time. Nobody pays for this extra time. And finally, there are some clinical concerns. And particularly it's important regarding the brain atrophy. We mentioned that in different models, brain atrophy predicts the prognosis. We know that several disease-modifying drugs reduce the degree of brain atrophy. But all these studies indicate results at a group level. So the question is, what about to the individual level with one of these measures? If I mentioned that the patient has a 0.5 brain volume loss in this year and a patient treated with a drug A or drug B, what is the impact in the management of the patient? We still don't know that. So this is the clinical concern that we have regarding particularly the brain atrophy measures. The second part of my presentation is related to the diagnosis. So we talk about the prognosis. Now, what we can do in order to improve the diagnosis. Because this is a real problem. And we know that there are other conditions, other disorders, diseases that may mimic MS from a radiological point of view. And I think that the most important confounder are the incidental findings that we detect with MRI in healthy adults. And this is an example. This is let's say a 65-year-old man without vascular risk factors, without history of migraine, that showed these abnormalities. So in some cases, we've seen cases in which, based on this finding, they make a wrong diagnosis of MS. And the problem is that these incidental findings, usually smaller and not so extensive, can appear in up to 10% of young adults. And we often see, again, that they make a wrong diagnosis of MS based on a wrong interpretation of MRI findings. There are other conditions that also may mimic MS, some vasculopathies, ADM, NMO, vasculitis, and a group of rare conditions such as sarcoidosis, Lyme, PML, and lymphoma also may mimic MS in some cases. So remember that conventional brain MR changes are not completely disease specific. And this is what is, I think, the most important problem. The incidental findings that we detect with brain MRI in young patients, up to 10% of them. And again, these lesions usually are relatively small. They mainly involve the subcortical white matter and the frontal lobes, something that is not exactly what we commonly see in patients with MS. And this has been analyzed in particular in North America. They realize that misdiagnosis of MS is a huge problem. The proportion of patients with a diagnosis of MS, that in fact they have a wrong diagnosis is relatively high, can be up as high as 10%. And what is probably most important is that many of them are receiving a disease-modifying treatment. And this has been demonstrated in this paper by Salomon, patients with many years of wrong diagnosis, and 70% of all these patients receive a disease-modifying treatment. So we need to improve the accuracy of the diagnosis. And the first step is to analyze the typical features of MS lesions in the brain and the spinal cord. I will not talk about that. But also, we have to keep in mind that MS is a clinical diagnosis. MRI supports the diagnosis, but we cannot make a diagnosis of MS based exclusively on MRI findings. We need the demographic data, the clinical data. Also, it's important to know the lab findings. We know that patients with negative oligoclonal bands is a kind of a red flag. We have to review the MRI just to be sure that the patient has MS or not. So these are the typical findings. I will not talk about that, but I would like to focus on some emerging features that I think that can help us in making a better diagnosis. And the first sign is related to the presence of the so-called leptomeningeal infiltrates. These infiltrates, mainly B cells, but also T cells, is a finding that has been described many years ago by the pathologists. It's a common finding, particularly in progressive MS patients. And as we will see from a radiological point of view, we can identify these infiltrates. But first, I think that we need to review that these infiltrates are associated to the cortical demyelination lesions, what we discussed before, how difficult it is to identify, and in particularly the so-called type 3 cortical lesions, those lesions that involve the outer margin of the cortical gray matter, the subpial demyelination. So it seems that this subpial demyelination, according to this drawing from the paper of Lucinetti, you see the subpial demyelination is associated with these aggregates of inflammatory cells that are located particularly in the deep areas of the sulci of the brain. Okay, so this infiltrates seems to play a role in gray matter pathology in general, not only to subpial demyelination, but also to gray matter atrophy, is associated with an aggressive disease course. And what is important from a radiological point of view is that these infiltrates produce leptomeningeal contrast enhancement, because these inflammatory cells produce a dysfunction of the blood-brain barrier of the leptomeningeal vessels. However, these areas of enhancement are quite different from the typical focal white matter lesions that enhance in MS. Why? Because the best sequence to detect these areas of enhancement is not a T1 weighted sequence. It's a T2 FLAIR sequence. And this is an example. This is an unenhanced, without contrast, T2 FLAIR sequence. We don't see anything. This is an contrast enhanced T1 weighted sequence. We don't see any leptomeningeal enhancement. And only when we combine a gadolinium with a T2 FLAIR sequence, then we see in up to 20% of all MS patients areas of linear or segmental enhancement, such as happens in this area of the Sylvian fissure. So remember, if you're interested in detecting these lesions, you need to perform a contrast-enhanced T2 FLAIR sequence. Usually, ideally, with a delay between the injection of gadolinium and the acquisition of the FLAIR sequence of around 10 to 15 minutes, which I know is not easy to implement in clinical practice. Another important information that we can get from different studies is that these areas of enhancement persist for a long time. And there are studies that follow up these patients for 1, 2, or even 3 years, and they show that in the vast majority of cases, these areas of enhancement persist. And also, in some patients that were treated with some disease-modifying drugs, these drugs, they did not have any effect in preventing the persistence of these areas of enhancement. Also, we can see that in progressive and non-progressive MS patients. But what is really important is that the persistency of these areas of enhancement is associated with disability worsening. So maybe, again, we have a new marker of disease progression based on the presence of these areas of enhancement that reflects these infiltrates of the leptomeningeal level. So let's move to the last part of these emerging MRI features. And these are features related to the focal white matter, the typical focal white matter lesions that we detect on T2-weighted images. And these are the central vein sign, the peripheral rim, and the slowly expanding lesions. So let's talk about first the central vein sign. And first, we need to remember the concept of the Dawson finger that reflects the perivenular distribution of MS lesions. This was already described by Dawson in 1916, and later on it was demonstrated that in the vast majority, more than 95% of MS patients, we can identify at least in the axial plane at least one ovoid lesion, an ovoid-shaped lesion, with the major axis of the lesion perpendicular to the lateral wall of the ventricles. And this is a nice radiological reflection of this Dawson finger. You see the vein and the demyelinating plaque surrounding the vein, and because of the axis of the vein, then it produced this ovoid-shaped lesion. Okay, this is an old concept, but the new thing is that now we're using a specific sequence, the so-called susceptibility weighted sequence. We can directly identify the vein because the vein has a high concentration of deoxyhemoglobin, and this substance produces a decrease in the signal intensity of the vein. And this is an example. This is taken from a paper by the group from Amsterdam, and they scan patients with MS. This is a zoom image of this scan, and you see the ovoid-shaped lesion, and with this sequence, you see the vein. So a very nice correlation with the pathological view. On the other hand, if you scan patients with a vascular disease, most of the lesions, they will not show a vein inside because they don't have a perivenular distribution. In some cases, in some lesions, even vascular lesions, we may see a vein. For example, look at this lesion, and particularly in those lesions that are close to the ventricular system. And the reason for that is because at this level, there is a high density of veins, and just by chance, you may see a vein inside a vascular lesion. But particularly the subcortical lesions, they will not show a vein inside. But the question is, can we identify the veins when we use a clinical scanner? Because the images I showed you before were obtained on a 7 Tesla magnet. But can we see the vein with a 3 Tesla, 1.5 Tesla magnet? And the answer is yes, we can. And this is an example from our institution, in this case using a 3 Tesla magnet, again an ovoid-shaped lesion, and the central vein crossing this lesion. But I think that this is the most important paper, and I really encourage you to read this paper published in Annals of Neurology a couple of years ago. This is the first time in which the authors use not only 3 Tesla, but also 1.5 Tesla magnets. And even using this relatively low field, they could discriminate very nicely between MS and other conditions based on the number of T2 lesions showing the central vein. And they established that the threshold is around 50%. But in MS, usually you see the vein in around 80 to 90% of all the lesions, while this is much less in other conditions. However, we have to keep in mind again is that if you are going to use 1.5, even a 3 Tesla magnet, is really useful to acquire this SWI sequence during or immediately after the injection of gadolinium, because you have to compensate the lower field strength compared to the 7 Tesla by using gadolinium, because gadolinium increases the paramagnetic effect of the veins, and then you improve the visibility of the veins. So using this strategy, you can see in this study that more than 80% of the lesions will show a vein. Another question is, do you recommend to use this SWI sequence for diagnosis always? And the answer is no. Only in difficult cases. And this, there are a couple of studies that demonstrate that in those cases with a diagnostic uncertainty, you can add this sequence in order to really establish a diagnosis or to exclude the diagnosis of MS. Again, in this paper, they use a threshold of 40%, and with that, they achieve almost 100% accuracy in making the diagnosis of MS. So again, this is a patient with lupus. You see that the lesions, none of them show a vein, while in this patient with a final diagnosis of MS, you can nicely see these lines or dots inside the lesions that reflects the veins. Another concept regarding the central vein thing is to consider other additional factors. The age of the patient and the presence of vascular risk factors. We know that when you increase your age, you develop new lesions in the brain that are not related to MS, but to aging process, to vascular disease. So it's quite common that we have in patients with MS that of older age, that they show both MS lesions and vascular lesions. Also, if you have, in addition, vascular risk factors, the proportion of lesions that you see non-related to MS is higher. And this could explain why in this group of patients, the proportion of lesions with a central vein is significantly decreased compared to younger patients without vascular risk factors. But despite this fact, you can see in this interesting paper that even in older patients, the threshold of 40% perfectly discriminates between MS and other non-MS conditions. So this is a summary of the central vein. Maybe we can use this threshold of 40% to discriminate between difficult cases of MS to other conditions. You can look that for example, in NMO, the proportion of lesions with a central vein is 0. In lupus is around 16%. In patients with migraine is 9%. So clearly lower compared to what we see in MS. And therefore, it has a potential to improve the diagnosis of MS in patients with CIS, with a radiological isolated syndrome, or in particular in patients with atypical neurological presentations. Let's move to the second emerging features in white matter, and this is the so-called hypointense rim. Again, we can identify this sign using SWI, susceptibility weighted images. This was initially described by Haki more than 10 years ago. We've been using this sequence since then, and we have some experience in detecting these rims. This is a nice example. This is a patient with an early phases of MS with a lot of lesions. And when you perform this sequence, you can see that some of them show these rims of hypointensity. Some are completely closed. Most of the cases are open, bigger, smaller, etc. And these rims of hypointensity reflects the presence of iron in the margins of certain types of lesions. Iron located inside the macrophages, inside the macroglial cells, and we will I will show you some evidence supporting this concept. These rims have two possibilities, the assessment of these rims. First, to improve diagnostic accuracy, and this is a paper we recently published in which we assess the presence of these rims in CIS in patients with relapsing remitting forms, primary progressive MS, and also in non-MS cases. And the most relevant finding of this paper is that although we detect at least one rim only in around 50 to 60% of all MS patients, we did not detect a single rim in any of the other non-MS conditions, giving this sign a very high specificity making the diagnosis of MS. These rims are mainly located in the periventricular white matter. This is another study also published very recently with a larger number of patients. And the good thing is that they show exactly more or less the similar results that we obtained in our single center study. They had obviously more patients, but also they could demonstrate the presence of at least one rim in around 50 to 60% of patients with different phenotypes of MS. And again, they found a rim in some patients with an inflammatory neurological disorder, but in non-inflammatory disorders, this rim never appear. So it's better to show an example. These are two cases, patient A, patient B, both of them with multifocal white matter abnormalities. And then we perform this SWI sequence. Patient A that had finally a diagnosis of systemic vasculitis. You can see that there are no rims, there are no veins inside the lesions, while you can nicely identify a rim and a small dot inside, which reflects the vein in several of these lesions. I think that the combination of rims and veins give almost 100% diagnostic accuracy of MRI in establishing the diagnosis of MS. But you have to obtain the proper sequence in order to be able to detect these abnormalities. So the question is, these rims really reflect iron inside the macrophages and microglia? Well, the answer is probably yes. And there are these two papers. The first one, they co-localize the presence of these macrophages and activated microglia with the presence of these rims, and they demonstrate that this happens. So MS lesions with phase rims, they have these iron positive cells, and also using a tracer with PET, a tracer that detects the presence of activated microglia and macrophages. Also, there is a perfect co-localization between the uptake of this specific tracer with the presence of these hypointense rims on SWI. And these lesions, in fact, reflects what the pathologists described some years ago, the so-called chronic active lesions. Lesions that have a center that is demyelinated, but in the outer margin, still there is some inflammatory activity mediated by the innate immune system, macrophages and microglia. And these inflammatory cells induce an ongoing tissue destruction that could explain, at least partially, disability progression in patients with MS. This is very nice data, also from the group in New York, that show that the presence and number of these hypointense rims reflecting these chronic active lesions also is associated with disability worsening, and is another marker, not only useful marker for making the diagnosis, but also to predict the prognosis. Finally, I would like to mention a new feature, and these are the so-called slowly expanding lesions. This concept is defined by the presence of lesions that do not show enhancement, are chronic lesions, that if you follow these lesions over time, there is a mild but progressive increase in their size. And you can see this lesion, no enhancement, grows and grows, also on T2. And also, if you look carefully, the degree of hypointensity in the center of this lesion also is increased. So this is the concept of slowly expanding lesions. Very difficult to identify these lesions from a visual point of view because the growing is very, very mild and very slow, but reflects also these chronic active lesions. So these are not inactive lesions, they grow. There is an ongoing tissue destruction that again could explain disability worsening. And this is a very important paper because for the first time, these authors established a correlation between a slowly expanding lesion with the presence of these hypo-intense rims reflecting iron in the margins of the lesion. So again, this is an hypo-intense rim. This is a 7 Tesla magnet. They follow this lesion for a period of 3.5 years. The lesion grow, and according to this paper that obviously included a small number of patients, those lesions with a rim, they significantly grow over time, while those lesions without a rim, lesions that are in fact real chronic inactive lesions, they have a tendency to decrease in size. This is another study from the same group with a large number of patients, a larger number of patients. And again, they could demonstrate that lesions that are rimless, no rims, they shrunk over time. And those lesions with a rim, they are stable or expand with a median expansion of almost around 2% per year. So those patients with more than 4 chronic rim lesions also reach a higher degree of disability and cognitive decline. And also those patients with rim lesions, they have a higher degree of brain atrophy. So another new marker based on MRI to predict disability worsening and disease progression. Again, this is a summary slide of these hypointense rims. Appears in at least one in around 50 to 60% of all MS patients, relapsing and progressive MS patients, is a radiological reflection of the so-called chronic active lesions that produce an ongoing tissue damage mediated by the innate immune reaction, and also could be a marker of slowly expanding lesions, but still there is some controversy. We need more studies in order to prove that. The iron, the rims, seems to disappear after a period of 5 to 6 years, indicating the conversion from this chronic active phase to a chronic inactive phase, correlates and predicts disability progression, and also maybe this marker could be used in future clinical trials that assess the efficacy of certain drugs to slow down this innate immune reaction. Again, this is another example, a patient with MS, a very typical and nice periventricular lesion in the frontal region. And then this is the SWI sequence. You nicely see the rim indicating that this is a chronic active lesion. So let me finish by the summary. I think that MRI, no doubt, plays a very important role in establishing the prognosis and the diagnosis of MS. We can rely on typical measures in most of the cases, but in certain areas, in certain difficult cases, we may add some additional sequences that could help us in the prognosis and making an accurate diagnosis of the disease. So I would like to finish by thanking all the group of MS clinic in our institution. It's a lot of people from the clinical, the lab, but also MRI, the radiologists. We play an important role in this unit. Thank you very much for your attention.
Thank you, Professor Alex, for this, as usual, very comprehensive and very new data, and of course we'd like very much to share the experience with you. We visited your center many times, and you visited us many times, and it's very interesting to share all these experiences. I would like to start with a question from our dear colleague. He is one of the eminent professors of radiology in Egypt, Dr. Yasser Abdelazim. He's asking about the central vein sign. Is it present in NMO and ADEM, or only in multiple sclerosis? So can it be used to differentiate these diseases from multiple sclerosis?
Yeah. Yeah, in NMO, it's clear that the lesions are not perivenular, and there is some studies showing that the central vein sign is very useful to discriminate between NMO and MS, no doubt. With ADM, there is less experience. ADM, we see mainly in children, and there is not a lot of experience on that. So I cannot really answer you about this question. So I don't have personal experience, and I'm not aware of studies that particularly assess the value of the central vein in ADM. But with NMO, it's clear that helps.
Also, a question from Dr. Yasser. Does PET MRI has any role in clinical practice in multiple sclerosis, especially that this machine now is available in Egypt?
The answer is no. I don't think so. We have to be aware that I'm not a fan of PET MRI in general, because when you buy a PET MRI, you don't have the best MRI, not the best PET. And now we have tools that can combine the images from PET and MRI and co-localize the findings. Probably in oncology or in neurodegenerative disorders may play a role, but not I don't think that in MS. And also, we have to be aware also that the tracers that we need to identify the inflammatory component, such as the one I show you to detect the microglia and the macrophages, is not a tracer that is easily available. So we cannot just use FDG to do that. So we have to be aware of that fact. I'm not a great fan of PET MRI in general, and in particular to MS.
Okay. Dr. Magdi, you are with us?
Yes.
Yes. You have any questions?
I haven't received any questions actually. So probably the questions are going your side.
Okay, so you have I have some other questions, but you have any questions to Professor Alex?
I will keep my questions at the end of the conversation, because
okay. Difficult questions. Okay, I have also a question regarding, this incidental finding, because this is very confusing, especially even here in Egypt. When you find this incidental finding, what is the best way to report about it? Because sometimes we have reports in Egypt, especially in Egypt, that this is suggestive of demyelinating disorder or suggestive of vasculitis, and actually this will direct the physician in a certain way. So, I mean, would you like to just put it as this is incidental finding for differential diagnosis, or you will guide?
Yeah, this is a very important question, because this is very common. So when we scan the patient for any reason, we detect this small foci of high signal intensity, non-confluent, mainly located in the subcortical white matter anterior. When the lesions are non-confluent, small, I mean less than 5 to 6 millimeters in diameter, I ignore them. So I mentioned this in the report. I found this incidental finding. I never use the word demyelination. I report always that these are incidental, and according to the low number, the location, the size, these are incidental findings that they don't need any additional study. Because it has been demonstrated that this type of lesion, the so-called leukoaraiosis type 1 lesion, according to the FACECAS scale, this is a normal incidental finding. and we have to, obviously, I check how is the corpus callosum, how is the infratentorial compartment, because these incidental findings are very unusual in the posterior fossa. And if I have doubts, then what I do is to scan the spinal cord to rule out the presence of lesions in the spinal cord. And in difficult cases, then I do SWI to detect the vein or the rims.
And for those incidental findings, you will suggest follow-up after 6 months or 1 year, or you just forget it?
I forget it. So if they are small, subcortical, mainly subcortical and mainly anterior, without involvement of the posterior fossa or the corpus callosum or the cortical gray matter. So, and this happens in more than 95% of the cases of these incidental findings. My final report is MRI exam within normal limits.
Okay. Also, there is a question regarding the thalamic atrophy. I mean, the thalamus is very easy to measure and to follow. Why not, despite there's a lot of literature about this issue, why not it's very popular like the cortical atrophy?
Well, I don't know, because maybe it's because it seems that the cortical gray matter is more relevant, but the thalamus is really a crossroad. And also the thalamus, it has a lot of white matter. So the distinction between gray and white matter is arbitrary from a pathological point of view. There is a lot of white matter inside the thalamus, not so much in the basal ganglia. So that's why we have lesions in the thalamus in patients with MS, and also atrophy, because there's a connection with all the white matter tracts. We can assess the volume of the thalamus, but it's not so easy, because if you look carefully to a T1 weighted image, the border between the thalamus and the internal capsule is not always very nice demonstrated. The reason why, because there's a lot of white matter in the thalamus. So we have tools that solve this, but it's not so easy to assess changes over time, longitudinally. In cross-sectional, it's relatively easy, but longitudinally, we have to be careful with
that. Regarding any role for diffusion study in multiple sclerosis, especially that, sometimes there is persistent restriction in the images, which might persist for a while, or you just forget it?
Well, I think diffusion weighted image is one of the best innovations of MRI ever. And the main advantage is that it's sensitive to many things and is very short. It takes 1 minute to do a diffusion weighted image. So we use diffusion as a routine. But the main reasons to do that in patients with MS is to identify complications related to the treatment. So we know that for PML is very useful, and we scan always the patients with this technique. But if we want to use this sequence to identify acute lesions as an alternative to gadolinium, the answer is we cannot do that. There is a lot of false positive, a lot of false negative. We know that in the very early phase of development of a lesion, there is a restriction in some of them of diffusivity, but we cannot really replace that for gadolinium. And also we use diffusion weighted images in patients with CIS in order to exclude alternative diagnosis such as stroke, but not as an alternative to detect acute inflammatory lesions.
There is a question by Dr. Rafat regarding sometimes you have new symptoms and you will do the imaging without any new finding. So any suggestion to use any specific techniques or any specific parameters to actually, if you know that this is the suspected site of the lesion?
Well, to be honest, in clinical practice, the best sequence is T2 FLAIR. There is nothing else better than this. Double inversion recovery is an additional sequence that we can recommend. It's not mandatory. It helps in the detection of lesions in the posterior fossa. But we commonly see patients in which the clinician suspects activity or new symptoms and we don't see anything. The question is because the symptoms are not, does not reflect a real relapse, or because we are not enough sensitive. I think that in these situations, we have to maybe to add a spinal cord MRI if you suspect that the lesion could be in the spine, in addition to the brain. But we also know that, for example, there is a study performed several years ago that in patients with a clinical relapse or a suspected clinical relapse without new lesions in the brain MRI, these are the patients that steroids do not produce any response, because probably the patient has not a real relapse, but worsening of pre-existing symptoms. When we see new lesions that mainly enhance, there is a good correlation between, there's a good response to steroids to the new symptoms. But it happens, but I don't have the answer. Maybe it's a wrong diagnosis from a clinical point of view, or because MRI is not enough sensitive to detect these new lesions.
But you will not go, for example, for functional MRI or...
No, not at all. All these advanced techniques are purely for research. They have no clinical value. The only exception is maybe perfusion techniques or MR spectroscopy to discriminate between a pseudotumoral tumefactive lesion from a real tumor, but not for normal monitoring of the disease.
Also, a question from Dr. Yasser regarding now we have drugs which can halt or prevent the cognitive decline, especially in those patients presented with the cognitive decline. In your practice, you will follow the brain atrophy or the measures for cognition in the MRI routinely on patients taking these drugs, or you will just do the routine?
My answer is no. I am not in favor to use brain atrophy for monitoring patients, even if they have cognitive decline. I think that the future on brain atrophy is, as I mentioned in my presentation, is at the early phases of the disease in order to predict the prognosis, because this can guide your treatment. But once the patient is treated with the best available drug or to prevent cognition, to assess in an individual level the degree of brain atrophy has a lot of confounders. Technically, and the pseudoatrophy effect, the presence of additional factors, obesity, vascular risk factors, all these factors also have an influence. Smoking, drinking. So there are many factors that prevent the use of brain atrophy for monitoring individually patients under treatment.
Okay, and now I guess I have ended my questions. I also encourage the attendees, if you have more questions, just put it in the chat box, and I will leave the difficult questions for Dr. Mack.
Actually, they are not difficult questions, but they are questions we usually face while dealing with clinical practice. Starting with the sometimes we have problems with the brain MRI and for differential diagnosis of other mimics of MS, excluding the migraine, of course. I mean, like collagen diseases or other diseases that can, to an extent, mimic MS. Now, what is the incidence of spinal lesions in these other diseases? Because we are relying to a degree on the spinal cord that if we find these lesions, then most probably then you have a case of MS. So in your experience, let's say with sarcoidosis, for example, or other autoimmune diseases, is the incidence of spinal lesions, could it differentiate?
Yeah, there is an old paper, I think that, from the Amsterdam group, published in Radiology I think maybe in 98, something like this, that they assess in particular this, and they found lesions in the spinal cord in around 6% of patients with these inflammatory conditions, non-MS inflammatory conditions. In patients with established MS, we find spinal cord lesions in 90% of the cases. So it's a huge difference. As a differential diagnosis in patients who started with symptoms, also we have to mention that usually in sarcoidosis, when you see lesions in the spinal cord are symptomatic. It's not common to see asymptomatic lesions in the spinal cord in these patients, or in patients with lupus, for example, the lesions are symptomatic. While in patients with MS, we see asymptomatic lesions in patients with non-spinal cord CIS in up to 30 to 40% of the patients. So it means that if you scan a patient with a difficult diagnosis and you don't see any lesions in the spinal cord, you cannot exclude the diagnosis of MS. But if you see lesions, then it's done almost. But the lesions should be small, located in the lateral columns, in the dorsal columns, short segment. We have to also to assess the features of these lesions. But I think that the frequency is very low. There is a condition that always is challenging, is in vasculitis. In primary vasculitis, we may see lesions, asymptomatic lesions in the spinal cord. Although the lesions are different, are small, punctate, diffusely distributed, not the typical ones in MS. But we had some cases with difficulties. But then we have additional features. We can assess the location of the lesions in the corpus callosum, in the cortical gray matter, the central vein, the rims, etc.
Thank you. I think just to comment, it's a very important point what you said, and I want the audience to hear that usually if you have spinal lesions in other diseases than MS, then most probably these lesions are symptomatic. This is a very important clinical point. The second thing also with the spinal cord is that sometimes we see cases where you have typical brain lesions are of MS, and then you see the spinal cord and you see a long segment. Okay, so it's as if the spinal cord is to an MO patient and the brain is to an MS patient. So my question is, can confluent lesions occur in spinal cord? Can it be a mistake? Let's say that you have a lot of multiple small lesions in the spinal cord and then they open together like the confluent lesions, or this is...
No, you are. I fully agree with your comment. This is a problem. I've seen cases that the MS clinic, they sent to me saying, okay, this has been diagnosed of MS, but I think that has a longitudinal extensive lesion. And this is not. This is a confluency, usually associated with certain degree of atrophy. But we have to look carefully to this type of lesions because they can mimic NMO. The only exception is in the pediatric population, because this has been described that pediatric patients with typical MS, they can have longitudinally extensive spinal cord lesions. But in the adult, usually is a confluence of chronic lesions that produce this mistake. Yeah.
No, one last simple, maybe very naive question, but sometimes it's important to ask because, you know, when we put the protocols for escalation of therapy, we sometimes we have to have relapses and MRI changes, both. Okay, so is it possible to have relapses without MRI changes?
Yeah, it can happen, but it's more frequent the opposite, that we see new enhancing lesions without relapses. But it can happen. It could be explained by different factors. I already mentioned that. First is that probably this was not a real relapse. We know the concept of, I'm not a neurologist, but the pseudo relapses may occur. Second, the lesion can be very small and we don't identify the lesion. It's located in a highly eloquent area, but we don't identify. Or what happens in many cases is that the lesion is located in the spinal cord. And if we don't include the spinal cord, and we suspect that the relapse is related to the spinal cord, then we will miss. And even if we perform a spinal cord MRI, is from a technical point of view is a little bit more difficult compared to the brain to detect new T2 lesions or enhancing lesions. So this can be the three reasons that explain why in some cases we don't see new lesions in a patient with a clinical relapse.
I'm asking you this question because we as I told you, have certain protocols for escalation of therapy, and sometimes you see the patients, they give you a history of a relapse. We let's say when you want to go to from first line to second line, or from second line to third line therapy, then you have to have documented relapse and MRI lesions. So the documented relapse, probably in the past history, it's not documented. You depend on the history of the patient. So when we see some patients, we see patients giving a history of relapse. We didn't see them actually in the relapse. They're only giving the history of the relapse. And you find the MRI stationary with nothing changing across the time of the relapse. So for us, it's a little bit doubtful that maybe this, as you said, at the first possibility, that this was possibly not a relapse. And because as clinicians, we tend to combine between the clinical presentation and the site in which you are looking for the new lesions, if there are any new lesions.
Yeah. I mean, but let me tell you also that I've seen several cases of new lesions very clear on T2, that after a certain period of time, there is a disappearance of the inflammatory component, there is a good remyelination, and the lesion, it happens this in 5 to 10% of the cases, the lesion completely disappears. So it's not visible anymore on T2 weighted images. Another issue, and this is my personal experience, when we use automated tools to detect new T2 lesions, we increase the sensitivity by a factor of 2. We double the lesions that we detect with the tool, because visually we are not so good. It's difficult in patients with a large number of lesions to detect a very small lesion. With these tools, we improve much more. And therefore, it's also a problem. And I think that I have quite a long experience in detecting new T2 lesions, and still I miss quite a lot of lesions when I compare this with an automated tool. So we are not perfect, the humans.
Thank you. Thank you very much for the Annie.
I have one last question. Now the overlap between the NMO and multiple sclerosis radiologically, especially for a patient presenting or having history of recurrent optic neuritis, and in doing MRI you will find many lesions, especially that we are using the stare and the face contrast and these techniques which will visualize the lesions. So what are the red flags which will indicate that you should go for more investigations for NMO and the MRI? Because there is these investigations now are becoming available and they are a bit expensive. So and you have to make a decision. Of course, there's a difference in the drug treatment. So yeah. What are the red flags, especially with a patient with history of optic neuritis and having lesions in the cord?
Well, I think that what for me are red flags is for example, the absence of a predominant periventricular topography of the lesions, the lack of the involvement of the inferior temporal lobe. This is quite common in MS, very rare in NMO. And in addition, to have this large corticospinal cord tract lesions is common in NMO. Also, the type of involvement in the posterior fossa with involvement of the floor of the fourth ventricle in those areas in which we know that there is an overexpression of aquaporin 4, then this is a clear red flag. If you have involvement of the optic chiasm, can be seen in MS, but it's very rare, quite common in NMO. If you have extensive lesions in the optic nerve, then it's another red flag. But particularly, I would like to focus on these areas of overexpression of aquaporin 4 in the floor of the third ventricle, floor of the fourth ventricle, periependymal regions, the dorsal part of the brainstem, large lesions in the hemispheric white matter, press-like lesions. All these are very atypical. But on the other hand, if you see very typical lesions in the temporal region, ovoid lesions, lesions involving the inferior margin of the corpus callosum, all these are very typical findings for MS.
Okay, thank you. I guess sometimes I don't have any more questions. So, Dr. Mac, do you have any more questions?
Thank you very much, Professor Rivera. It's a pleasure to be with you. Thank you very much.
So if there is no more questions, of course, we would like to thank our dear guest, Professor Alex Rivera from KimCat Barcelona, and I hope next time we will have him on site in Egypt, maybe with the opening of the new Grand Museum. Promise, we will invite you to attend the opening.
Looking forward for that.
Yeah.
So let me say thank you very much. It's a great pleasure. I have very good friends in Egypt, and it's for me one of the favorite places in the world. And I hope that you will have a very nice winter. I hope that the second phase of this epidemic problem will not go to Egypt. We are suffering this in Europe, but we will try to keep it in Europe and not to the rest of the countries. So very happy to be with you today.
Thank you very much. Thank you. It's a pleasure to be with you, and we hope, as Hani said, to meet you in Egypt soon. Anyway, you can go to Egypt if you have a certificate, so no problem. You can come even now. Things look normal to us in Egypt in the current time. Everybody's in the streets, and all the shops and the restaurants are open, and people are unfortunately not even wearing masks all the time. So if you feel tight in Barcelona, then you can
go
and stay a little bit. Only bring the certificate for the COVID negative.
Okay.
No problem after that. Yeah.
Okay. Thank you very much. Have a nice evening,
Thank
and hope to see you soon.
Thank you. It's a pleasure being with you. Thank you. Bye-bye.